The single most important factor that we use in deciding on upfront treatment is indeed the performance status of the patient. And here we're referring to patients, how active they are during the 24 hours a day, using the traditional way of assigning performance status to patients. That is really very important. It helps us in two ways. One is it avoids giving a toxic treatment to somebody who will not be able to tolerate the therapy. But on the other hand, we also know that patients who have better performance status also respond better. So in terms of giving combination chemotherapy that we're doing now, the role of the performance status is very important for us. There are other factors that I take into account. For example, age. Patients who are older, especially over the age of 70 or 75, their tolerance to treatment will be less than those who are younger, and some regimens might work better in terms of tolerance or even efficacy if we choose the patients correctly, the older patients. Remember, the median age of patients with pancreatic cancer in the Medicare registry and other registries is 71. So these are patients, half of the patients we see are over the age of 70. Other factors include the performance status of the, in addition to the performance status of the patient, include the liver function test, for example. That's really very important. But one of the things which in my practice is very important is also the patient preference. Because when I see a patient and we talk about treatment that is not curative, it's palliative, it's very important for us also to talk to the patient about what to expect from the treatment, both the benefit and the risk, the side effects. And the patient is involved in deciding which treatment will work best for the patient. I have my recommendations, but the patient also has the chance to really go over the recommended options and be able to make a decision on which one they want to pursue. Now, one of the things which we were successful in colon cancer was to do longitudinal treatment plans, which means that we are giving the patient the option of going on one treatment, but also having a backup or second-line treatment if the first-line treatment does not work. And indeed, in colon cancer, we managed to double, triple, or quadruple the survival rate because of the exposure of these patients to multiple lines of treatment. Now, when you do that, you also have to have a strategy for the patient. And the strategy for the patient and which drugs you want to use in sequence depend on what you have. And certainly the availability of the nanoliposomal irinotecan with the 5-FU helps us to think of how to design a strategy, which is something that's happening for the first time. Remember, this regimen is the only regimen that's FDA approved for second-line treatment. So now we have a firm strategy that we can apply to patients. In this respect, the nanoliposomal irinotecan-based regimen includes 5-fluorouracil. So certainly it's a good regimen to use after non-5-FU-based treatments in the frontline treatment. And in fact, the clinical trial Napoli-1 was in patients who had frontline gemcitabine-based therapy. When they were failing the treatment, they went on the nanoliposomal irinotecan plus the 5-FU treatment.
In terms of selecting or finding selection strategies that would tell us which patient should get what regimen. Should we get gemcitabine, nab-paclitaxel? Which patient would get gemcitabine, nab-paclitaxel? Which patient would get FOLFIRINOX? Or, very rarely, which patient would qualify for gemcitabine? There is no good predictors or anything that would help us predict what patient falls into a particular basket. These agents, other than gemcitabine alone compared to FOLFIRINOX or gemcitabine, nab-paclitaxel, nab-paclitaxel, and FOLFIRINOX have never been compared head-to-head. So we don't know the differences between the two when you put them head-to-head. If you look historically, FOLFIRINOX seems to have a higher response rate, a higher survival. Gemcitabine, nab-paclitaxel, although better than gemcitabine, historically has not shown the same level of response. However, it is very dangerous to actually do these historical comparisons because they're completely different patient populations. In fact, you can argue that the gemcitabine and nab-paclitaxel study included patients with poorer performance status also was conducted in countries that may not have access to second-line therapies, etc. So it's very difficult to do the comparisons. In fact, there's a study, again, mostly observational, from the U.S. Oncology Group. They looked at their data in 1,000 patients, and what they found is whether you start with gemcitabine, nab-paclitaxel, or FOLFIRINOX, ultimately you achieve the same survival, which essentially means that a doublet or a triplet induce the same level of survival, although, one may have a little bit higher response rate. Ultimately, the gold standard is survival. And I do believe that when we look at other cancers, gastric cancer, colon cancer, breast cancer, others, what makes more sense is to essentially go to doublets or even singlets sometimes and just learn how to sequence regimens, the regimens that are available to us, rather than to throw everything in one basket. So the kitchen sink approach. The kitchen sink approach in this situation, when you have multiple lines of therapy that are active, doesn't make sense. It essentially, by sequencing rather than doing that all kitchen sink, you reduce the risk of toxicity and you induce about the same benefits in patients. So now that we have nanoliposomal irinotecan plus 5-FU or MM398 plus 5-FU that has shown activity and a good placing in the second line versus 5-FU, one could argue that rather than use a triplet, which is highly toxic, FOLFIRINOX, in the first line, rather use a more rational doublet followed by a doublet approach in patients who may be eligible to it with less toxicities and induce the same results. So other than clinical selection right now, meaning that patient enters through the door, you assess their performance status, and you decide on what regimen they may end up being, we don't have any other way to select those patients.